This is a part 2 video of an interview between Luke the documentary and myself. He's interviewing me, asking me about my case. And part 1 is on his channel. So go over there, subscribe, show him some support. He's another patient in the sleep disorder breathing space looking for answers, and he's doing amazing work, and he covers stuff that I don't cover. So go over there. He's also doing a giveaway too, so you go check the description box. Everyone asked for my story, and I think Luke did a good job at getting to all the details of that. So this is what this video is all about. On a completely unrelated note, my wife and I are going down to Argentina and also Brazil. So if anyone knows of any providers who do DISE down there and what the prices are, and if they can recommend anyone, that would be much appreciated. I will be checking the comment section. Also, if you want to rent your place out too, just send me an email. I would be interested in hearing what the offer is. I hope you guys enjoy the video. If you have any questions, just let me know.
Have you ever had any kind of TMJ problems, and did you experience any like relief or the opposite?
Nothing like that, no.
How's your jaw opening? Mine got wider from jaw surgery. I don't know if yours increased, stayed the same.
I think it got worse, and maybe that's because I didn't do anything to. I feel like I used to be able to open it more, and there's ways to measure this too, right? And maybe you've done that.
Yep.
There's like literal things you stick in. I've never done that. I probably should have engaged in like these exercises and stuff to kind of help facilitate that, but I didn't do any of that, and maybe I still can. I think I even mentioned this in one of my videos, that pretty much what I'm just relaying to you right now is that maybe you can still do this. I'm not sure. Maybe a myofunctional therapist can comment and let me know if it's still worthwhile to try to open my mouth more, but it's not causing problems, but I can tell that it's less than what it was before, for sure.
Gotcha. Yeah, I think they would argue that they could help you out with a wider opening. How about, do you plan on keeping your plates in?
Yeah, again, no problems there. I don't feel why. I don't know. Maybe I'll look into it one day. I'm sure there's probably no consequence. Did you look into it at all? You got your plates removed, right?
I got my plates removed, but that was because I'm assuming I want to get expanded, and mine was over the midline. But I know they do it like for comfort or kind of just like housekeeping in Europe, from what I hear. But you know, there's always people saying, "Oh, you know, it's better always to get any kind of metal out of your body." But I don't know if I believe that.
Yeah, that's the only thing I really think about it. I'm pretty health conscious, and I wonder, like, is this like leaching into my system or something? But I imagine what's used is literally the material that doesn't do that, because I imagine there's some sort of regulation around it, but maybe I'm being naive. So
yeah,
I'll look into it. But what are they?
I would
they're
imagine
usually titanium, right?
Yeah, they're usually titanium. I'd imagine you're okay.
Seems like a lot to go through just to like remove a tiny piece of titanium, you know? Like, and there's risk to that. Did they talk about that with you? Like,
yeah, there's like relapse. Is that what you're referring to?
Well, that, or just like, I mean, the tissue begins to grow around it and stuff. You know, there's bleeding, and maybe, I don't know. Surgeons could probably answer a lot better, but I imagine it's like a decent amount of risk just to get some plates out.
Yes, yeah, that was my experience. Or I guess it's harder, especially when you have the plate that goes over the midline. I don't believe they usually do that without general anesthesia, where at least these lower plates they can do just in office without general anesthesia. Maybe even top plates if they're not across the midline. But my own plate removal was actually sort of involved, and I almost passed out at one point, and I was having like lopsided swelling, so I had to get like drained. It was actually, and I had hives. I broke out in hives because of like some foam I was sitting on, or I was placed on, like some positioning foam. So it was like it shouldn't have been a rough procedure, but for me it was. And yeah, I'm sure there's a bunch of complications. I'd imagine you're fine. I'd imagine most people are with the material they use.
Yeah, it seems like the surgeons typically advise against it too, unless there's a reason, you know, like they think it's not a good idea. That's the impression I've been left with. But again, yeah, if you're going to expand, you don't have a choice, right? You gotta remove that.
Yeah. Yeah. Yeah.
Or you could be the first case that breaks the titanium plates with through the expansion force. Oh, you know what though? Actually, did you talk about like maybe just removing like a little bit here and a little bit here, or is that not?
I theorized that on my own, and I was even like, man, maybe I'll just get like, I have a lot of faith in like my brother, and like I'm frugal, so I'm like, maybe I'll just like get my brother to like cut my plate down the middle. I didn't do that, and I asked Ken Hooks, and I just asked for his opinion. He was like, just get them all removed all the way. So I just went with that. But after talking to a lot of the FME providers, they would be more comfortable if I had my plates in somehow without, of course, that midline. So maybe if I could go back and do some sort of way where I would just cut this, or remove this kind of area, I would probably do that, because it seems like it complicates expansion a little bit more.
By removing them all, you're saying?
Yeah, they would rather have some more structural integrity there with those plates than not.
That makes sense. But you didn't mention that to Alfie, hey? You didn't say, hey, can we just like, what about cutting right here?
No. Yeah. It was more of I consulted elsewhere, and then I was like, I gotta figure this out. It was like a whole insurance process and stuff, so I didn't talk to him about it, besides maybe the day before. So, how about, do you have any, go ahead.
No, I was just gonna say that's hilarious that you considered to save money by just cutting your plates.
Yeah, I need to probably sit in on a jaw surgery just to like be humbled about their expertise. But for whatever reason, in my mind, I'm like, I don't know. I know some capable people who got steady hands. They could figure it out or something. I'm sure that's probably largely delusional, but that's kind of where I'm going from.
Yeah, I was like deep into frugality at one point in time. I read this book called Early Retirement Extreme. It was written by this German guy, and he basically like mathematically demonstrates like how quickly you can retire, and like all the things that you can do to save money. And it was just like the most extreme stuff. Like some people would like walk 2 kilometers just to shower for free, and they'd make their own soaps, and never buy a car, of course, right? You just bike everywhere because that's exercise plus. But the frugality stuff, I always find that funny and interesting. It's you can go to super extreme lengths to save some money, but I do think we could benefit from being more frugal in general. We're just so wasteful and consumptive. But yeah, it's hilarious. That should be in the book. The considered cutting your own surgical plates.
Yeah, if you get jaw surgery, consider getting your brother to cut it. How about you pay cash price with Bobek? I know he's usually doing that with his patients. Yeah.
Yeah.
And that ballpark is like $25K, $30K USD.
Yeah, I paid $27K, so that was for anesthesia plus the surgery in the clinic. So I didn't go to the hospital, and I left the same day back to the hotel. And then plus whatever the first appointment was, I think it was like $500. Okay. So probably 27.5, everything, and then travel and hotel. So 28.
Okay.
Final
answer. Right. He often does that. I'm often mentioning his name to people who reach out to me who are either uninsured or, I don't know, international. And they're like, maybe I want to go with Alfie. And I'm like, well, if you're going to pay cash, I know his cash price is like, I think around 40 to 60K. And I know Bobek, and I trust his work. Is that sort of how you landed on with him? And not being, say, insured in the US, et cetera?
Yeah, it was factored in, but honestly, like even if they were all the same price, I would still probably go with Bobek. There's 1 or 2 other guys who would compete for that position. Probably Gunston, he's got a pretty good reputation.
Sure.
Maybe Casey Lee, but those 3 I think would be my highlights. I would still choose Bobek even if he was more. The other thing too was that he's right next door to where I grew up, which is helpful. And also I think what really like played a part as well is that I've been in this space for a long time, talking to a lot of other people who are very involved, who are very thoughtful, and who are reliable in their thinking, who are looking at literature, who are going to these consultations, who are doing anything possible to get an improvement. And several independent opinions also concluded that Bobek was probably, or at least close to, their top choice. And that means a lot to me, because there's only so much work that you can do, and for the longest time, and even to this day, like, which is why we have channels, anecdotal content and experience is actually very, very helpful, right? So just the fact that so many other opinions who I really quite valued and trusted also meaningfully communicated that they wish they went with him, or they would go with him, or they think they want to go with him, it definitely moved the needle for me.
Mm-hmm. That makes sense. Yeah, I actually follow him on TikTok. When I post there, I get to see some of his posts, and yeah, he's top notch for sure, from what I can tell.
Did you ever see me on that? Because they asked me if they could put me up, but I don't know if they ever did. But I didn't know they had TikTok. But
yeah, he has a TikTok. It's like, maybe it's like Seattle Surgery or whatever his brand is called. But yeah, it's mainly just him talking to the camera, like answering people's questions.
Yeah, Bobek's a winner, man. I think he's being slept on, and he was just so professional. He was so generous with his time. He was very self-aware and acknowledges where his limits are, which I'm sure you've learned that some surgeons have difficulty with, right? And yeah, it was just a great experience. I have no complaints. Mm-hmm. I phoned him at 5 a.m. or something, like the next day. He answered the call because I wanted to leave.
Wow.
I slept over, and you know how it is, right? First day after surgery, I think I slept a couple hours in the hotel, and then after a while I was like, okay, let's go, because I fell asleep probably around 8 or something, and so it was like super early in the morning, and I walked over, and they weren't open yet, and I wanted to get down to the ferry to go back to Canada on the same day, but it left at 8 a.m., and I called him, and the guy answered the phone. He was up. So
you might have panicked him.
Yeah, maybe. Yeah, maybe he was upset that I gave him that call, but maybe he was already up. I think he was already up. I think he's a morning person for sure, because surgery starts. I mean, he was talking to me on the surgical day, I think at like 7 a.m. or 7:30. The whole office was up and running at that point in time, and I think it started at 8. So he's got to be getting up pretty early. That's my guess. I don't know. Anyway, It's just a bit of useless information, but you can choose.
I wonder if he could charge more, and he's choosing not to. Kind of back to some of the earlier conversation we were having, because it seems like he's a good resource to have here. I think so.
Yeah, I've thought about that too. Maybe he's strategizing to build his reputation, or maybe he's just in it for the love of the game, man. That was the impression that I got. Respect. Like, I think he likes doing surgery. So, I don't think he's interested in driving people away by higher prices. I think he likes that's my guess. Or it could be strategizing. Maybe build a reputation, and later on you can, like a thicker reputation in a field that's pretty competitive to have a reputation. But I think he just loves surgery. That was my impression. I think he just really likes to, I don't know why, I can't remember what random pieces of information have formed this opinion, but I've just been left with the impression that this guy just loves doing surgery. Like, he just enjoys it, and he wants to solve these cases, and he wants to actually do the operations. I think he enjoys the operations. I'll ask him. I'll try to get him back on and be like, hey man, what's the deal? Why are you selling these for $27K? You just love this stuff, or come on.
Exactly. Would he be, I don't know if he does the procedure, but would he be who does your DISE or fixes you, say, an epiglottis, or who would you be going for?
So he doesn't do either of those things. From what I understand, he defers to his ENT colleagues. And so for a DISE, I was thinking Kazarian, but I might get wrecked by the international prices or whatever. I think
Right.
Do you know how much it is? Have you ever had someone quote you a Kazarian DISE?
I could tell you, I know somebody who's about to have surgery with him, but I don't know it off the top of my head.
I think I heard 8K USD, which is just brutal. But I don't even think that's him. He just works for the UCLA network, right? So he's not setting those prices. So I probably won't go with him because it's just, at least for a baseline DISE. I'm not saying I want to get a bunch of DISEs, but I actually am going to ask him through email.
The DISE is 8K.
Say, hey, I think so, but I could be wrong. I wouldn't put it past. I mean, it is UCLA network. It's Los Angeles, right? It's like super high society. I wouldn't be surprised if it's up there. So my wife and I might go to Europe. So I'm going to ask Kazirin if he knows anyone over there who's a bit more affordable, and or maybe just start doing some research and asking others and going on the forums and stuff and seeing if there's anyone else. I just talked to a guy in Canada who went to Toronto, and there's this lady who does DISE there. I think that was 4K Canadian, which is still kind of steep. We're talking like a pretty short appointment, but I'd like to pay less than that. I think Dr. Movahead is actually pretty cheap. I think he's like less than 2K, if I recall correctly.
Okay.
But and then if you want stents, or not stents, sorry, splints, I think he calls them. Like I think they'll like customize some mandibular splints to keep your mandible forward through in the test as well. I think it jumps up to like 3 something.
Okay. That's not horrible. Not horrible.
Yeah. This is the other thing, right? In this space, it's like we don't even. You think there'd be like a directory like for all the prices of this stuff, but it's just like that's like 20% of the game. You got to get out there and just like ask people and go to consultations and sleuth on the internet for prices for these treatments as well. And they're all over the place, you know?
Yeah, I know. There could be a big range as well. And then trying to get insurance, at least in the US, can be its own game. Mine got approved first chance, so that was lucky. But now that I got you, I do have a big question I've been waiting to ask. As CPAP friend, do you have a sort of summary on what you would maybe recommend in terms of, say, PAP therapy advice, just general advice, short and sweet for people who are in this space? So maybe you could direct it towards OSA and UARS patients or these more stubborn patients, however you want to take it.
Yeah, so skeleton, like backbone, generalized advices. APAP actually is kind of helpful to try for like 1 or 2 or 3 nights. 1 second. It's going to open the door for someone. Okay, throw APAP on. This is just completely theoretical patient, right? Throw APAP on for 2 or 3 nights, see where it kind of evens out. Try fixed PAP up around that. And if, obviously you got to look at your data, make sure you're not leaking, check for centrals, check for continued signatures of arousal. You're probably just the only thing you can really do on CPAP is increase the fixed pressure until things either get worse or better, right? After that, you go to bilevel, provided you don't have any central stuff, right? And usually what I tell people is the ResMed clinical guidelines is a good starting point, but if you've already done CPAP, put your EPAP somewhere close to the CPAP pressure, which was best. Maybe start around a pressure support of 3. Leave all the fancy settings aside to begin with, and then incrementally increase the pressure support by 0.2, 0.4, etc. Do that with the same philosophy in mind. Either things are going to get better or things are going to get worse. After that, it gets a little bit more nuanced, but depending what your phenotype is, things like increasing trigger sensitivity is helpful for UARS patients and people who are continuing to deal with respiratory effort. Sometimes turning easy breathe off and reducing rise time, paradoxically, is better. Make sure your Tmax is not too low and cutting off your breaths. I don't see too many positive changes with cycle sensitivity. Usually medium is where it should be left, but I have seen cases where people actually notice and feel a better difference by changing that. But I'm just going to leave that aside because I can't really say much more than I think cycle sensitivity should be left on default for the most part. What else can I say? Everyone with obstructive problems, not medical advice, should try ASV at some point in time. We don't really have strong indications for who's going to benefit, but clearly some small percentage of strictly obstructive sleep disorder breathing patients, so URS or even apnea, OSA, do best on ASV. The theory is like, it's just addressing variance better. It's more comfortable. But I would tell everyone to try ASV at some point in time. And I think that you can proceed through all of this stuff within a month or two. And after that, you can add more nuance by doing stuff like combination therapy. So anything that's going to help or assist PAP therapy, from mandibular advancement devices to the INAP to adding adjunct therapies, for example, for loop gain. What else can I say? Prioritize leaks. If you're leaking, it's a confounding variable, and it's really difficult to speak to your quality of therapy if there's quite a bit of leak. There is no clinically meaningful threshold for leak. 24 liters per minute on ResMed machines is like the point of no return where the machine is compromised, so you can keep that in mind. But beneath that, or aside from that, we don't really know how much leak is a problem or disruptive to your sleep, so you should just try to eliminate it as much as you can, and you should prioritize it. That's the gist, I think. I think that covers like 90% of the whole picture, maybe more.
Gotcha. And how about masks? Of course, if you're mouth leaking, either trying to keep that mouth shut if you can. If not, switch to a full face mask and use one with the least amount of surface volume as possible. Or
yeah. So
with that?
I think in general, for a variety of reasons, nasal and pillow masks are kind of what the ideal. But there's reasons that people are not going to be able to make them work, right? So if you are opening your mouth, or you have mouth leaks, a couple things you can do. There's the chin strap, there's the soft cervical collar, there's those plus taping. But if that doesn't get you to where you need to be, then you probably have to switch to a full face mask. In general, if there's a leak, what I tell people is like masks are kind of like shoes. There's only so much I can say to you about how well a shoe is going to fit your foot. You kind of have to put it on and try it. And the very best thing that can be done to improve your mask experience or to get rid of leaks is to literally just use a different mask, or to use a different component size of the mask, because there's many masks which have components to them. You can break them apart into pieces and change the sizes there. There's mask liners, and obviously higher pressures and higher pressure supports are going to translate theoretically to more leaks. And full face masks, you want to make sure that you're not pushing, especially if you're compromised in that dimension, that in the AP dimension, that you're pushing the mandible back further. That's like the worst thing you could possibly do. Yeah, I think I covered most things.
Awesome, thank you. And so if they're trying all this, say they end up actually not getting much, if any, benefit, what, after 2 months, scrap it, move on, look for other treatment?
Yeah, I would add.
There's conflicting opinions about. Oh well, it might take 6 months. Just stay on that CPAP, APAP, auto PAP, and just wait 6 months. It's going to kick in. What's your opinion on that?
Yeah, my opinion is I think that there is some truth to that, but it seems like the majority of patients experience benefit rather quickly, and so that's the exception. That's going to take a lot of time. But I wouldn't rule it out as a real possibility. I do see that there's some literature that shows certain structures, for example, in the brain have taken like at least a month, I can recall off the top of my head, in one area to kind of regenerate and recover from the stress and the damage of sleep apnea. But I think that it's mainly a disservice talking point that providers and people who work in sleep medicine are saying to patients that you just need to wait some indefinitely long amount of time that we don't really know how long it is until things are going to get better, when meanwhile they could just have like horrendous data, like for example what I had way back in the day, looking back and seeing VERAs just everywhere and flow limitation everywhere and arousal signatures everywhere and leak. I think once you've cleaned your data up, give it some time if you have it in you, like, at least a month on the same settings to calm things down and to recover and so on. But I would also say I can't I can't say that with any meaningful amount of data to support that. And yeah, it's just never been presented to me, and that could be because I just haven't been exposed to it, but I would think that it would have come across my table by now, because I've had this conversation with everyone, with Ken Hooks, with my professors in sleep medicine, with Dr. Rama, and I've never heard like some obvious answer like, yeah, you got to give it at least 4 months because look at this study. It showed that, 20% of patients only actually experience benefits at the 4-month point or something. Doesn't exist as far as I understand.
Gotcha. I was thinking about logistically, if someone's trying to not necessarily speed run, but try these different treatments. I think generally my advice, this is not medical advice either, but if someone comes to me and they seem to be, RERA heavy, tall and thin, just not the classical OSA patient, I perhaps might recommend instead of getting a CPAP, I'd get a bi-level to start. And then they can start with that CPAP setting and then quickly, switch to the bi-level setting to see how that might work for their case, but also save money and not have to buy a separate machine. The frugal mindset kicking in again there. What's your opinion on VCOM in this new KPAP? I don't know if you've looked much into it.
I really try to base my comments and opinions off of what evidence is available. What I can say about both of those is I've basically seen no KPAP evidence. And VCOM, I've spoken to enough patients who've anecdotally told me that it results in better quality therapy, and I believe it. It's just not clear who that is and why. So yeah, I think VCOM's probably worth a shot. And there's all this KPAP buzz, but I mean, have you seen any literature or anything about KPAP? I haven't. So I don't know. I don't have anything to say about it really until you got to remember, like, there's like billions of people who probably have this. They conservatively estimate at least 1 billion have an AHI above 5. So there's a lot of money to be made by presenting or marketing a solution in a solutionless domain in some sense, right? So I've been hearing about KPAP for like 5 years probably. And I don't even know someone who has a KPAP machine. I've never seen KPAP data. I've never seen sleep study data with KPAP. Does it exist, and is it, the solution for everyone? Maybe, but until I actually get to experience some evidence of that, I can't really say anything.
Gotcha. I was at a recent conference, my first conference regarding like sleep medicine, sleep disorder breathing, and there's a company there selling rings. Rings. It's only a ring, right? And it's used to be an at-home sleep test, and they are claiming, and I was trying to pick their brain on how they were coming to this conclusion, but I didn't get to talk to them long enough, at least for an answer that was sufficient. But they claim they can measure RERAs, respiratory effort-related arousals, through a ring. Are you familiar with that type of technology, and does that make sense to you? Because to me initially, I'm like, well, how are you measuring respiratory effort through whatever parameters you're getting from, I don't know, say the pulse ox and whatever else? I didn't quite understand. I wonder if you do.
Yeah, I think you can, with the right amount of data, have a proxy for a RERA, and there's lots of, here. I would say to them, show me the PSG compared data that shows the correlation between the RERA detection on your ring and the PSG. That's all I would ask. I'm assuming they haven't done that, because I would assume they would want to present that if they have. I don't want to sound too bad here. Maybe they've done that, maybe they haven't, but that would be the first thing to look at in order to support the claim, right? And if you had that evidence, it's natural to think that you would want to present that, to go, hey, look, this data is statistically significantly correlated with the PSG detection rate of RERAs. Obviously, right? And you got a sleep conference. I mean, what could be better? So I think it probably estimates RERAs just like the WatchPat does. So yeah, I think like through pleth and through pulse rate and through movement, you can statistically guess if it's a rear or not, and you could probably get that quite up there, probably. I'm just guessing 85%, 90%, maybe 80%. So yeah, I think there's probably a bunch of false positives and false negatives, but at the same time, it's also probably useful and is detecting maybe the majority of rears. I think it's possible. Yeah, I mean, that's what the watch pad is, right? That's all it is. It's just measuring peripheral tone, pleth, and heart rate, and then making a statistical guess based off of however they train these algorithms.
Okay. What is the watch pad? I've never done it, I kind of forget.
Yeah, so I think there's a couple different kinds, from what I understand. But the general one, is the throwaway one, I believe is just a wrist monitor and over the finger. Okay. And it does peripheral arterial tone, like pleth / pulse. I don't know why there's like a million flies around me right now.
That's okay.
But the watch pad is actually a pretty useful device. It's pretty decent at identifying upper airway resistance syndrome. I think it inflates RDI on average, and I'm sure actually they're a pretty big company, so I'm sure they have some robust studies available that show how correlated it is with level 1 PSG. I'm guessing. They're a big company, right? And Watchpad is pretty popular, so I think it's pretty decent at guessing, but there are reasons to do level 1 sleep studies as well still.
Gotcha. And that's a service you offer yourself, right? Can you get into what you might offer?
I just, right now, yeah, I can send level 2 sleep studies to people in the US, and I can remark level 1 sleep studies. But I don't have a level 1 sleep study. I might go work with Rama, we're talking about that, and offer that NPES, which is like, you know, the gold standard for identifying upper airway resistance syndrome. But the one I send out is level 2, which is a Watchpad's level 3, so it's a little bit better, theoretically speaking. But I you do
multi-nights, right? You do multi-nights.
Yeah, you can have it for 3 nights. Yeah, so you can do with PAP therapy, without PAP therapy, or however you want to slice up 3 nights.
Okay. And then you still do PAP scoring or PAP consultations and the like?
Yes, I still do PAP consultations, but I try to tell everyone they don't have to come to me at the same time.
Okay.
And I prefer to do because there's people out there who do understand how, like Oscar and Sleep HQ, and they'll like answer these things for free as well, right? Like, I think the value that I add on top of that is more just like having a lot of experience in sleep medicine and with sleep testing and stuff. I'm trying to move in that direction a little bit because I think these forums are actually pretty helpful, and there's like a good handful of people who understand it well enough that people don't have to pay money to have consultation. But the sleep study stuff is something different. But yeah, I have PAP consultations. I'm just trying to help people.
Yeah. Nice. I like it.
I've been wanting to do like case studies, you know, and just do enough case studies and just present them on the channel that people can find their phenotype, you know. They're like, oh, this guy's data looks exactly like mine, and then try the changes maybe. I don't know. But everyone's a little bit different, right? One size fits all, I think we've all learned isn't really the answer. But
No. And we're both tall individuals, right? You're like 6'2", something like that.
Yeah, 6'3". You're like huge, right? Like I never. The only reason I know that is because like I think it's been mentioned, but like I never thought just watching your videos that what are you like 6'5" or 6 or something like this?
Yeah, I'm 6'5". Yeah.
So your brother too, right?
I'm thinner now. Yeah, my brother as well. Yep. But yeah, I'm 6'5". I'm usually on the thinner side, but I've been as much as like 220. But yeah, tall and sleep disorder breathing. I right with our. There's definitely a correlation or causation there. Wondering if you blame part of your own case on that as well.
I don't think it's my height. I just think some things went wrong through my developmental periods, whether it was cigarette smoke or pet allergies or just the food. I'm not sure how much you've dug into this as well, and there's books and stuff on this, and I think Alfie has spent quite a bit of time looking into this, but as far as I understand, but correct me if I'm wrong, we don't know for sure. We think it has to do with, a lot has to do with the food and the stress that we're putting on our jaws, which we don't put on our jaws anymore, and indoor living, all these particulates in the air causing nasal inflammation and encouraging mouth breathing and so on. But what do you know about that? I'm just curious. Like, do you know what the root cause is or where the literature is with that? Or
I certainly don't know what the root cause is. I have not seen someone, at least that I would trust, confidently claim they know. But yeah, all those things that you mentioned, diet or nutrition, air quality, there's lingering mouth breathing, tongue ties, lip ties. Alfie emphasizes lack of using the musculature, right, of your jaws, of even your tongue. But I think there's even more to it. I'm sure it's has multiple factors, plenty regarding it, in my own opinion. But yeah, I know that, I've talked to some providers who are like, since you're taller, you have longer dilator muscles in your airway, and so that will make you maybe more susceptible to collapse than the average person. But that's kind of all I'm running off of. But I think the UARS type patient often is, right, like a tall, thinner patient.
Yeah, there's a famous equation that gets passed around in this space. I think it's like Bernoulli's principle or something. I could be way off, but I think in the equation it's resistance equals, and then there's variables, and then variables in the denominator as well. And one of those is radius to the fourth power, which is why you probably hear people say, if you increase the radius of your airway by 2 millimeters, and it's 2 to the power of 4, actually decrease in resistance. And now on the numerator of that equation is length, if I recall correctly. Let me just look it up real quick so we can give the audience resistance equation. Yeah. R equals resistivity times length divided by cross-sectional area. It's one version. So yeah, length is in the numerator. So that does make sense. Like, resistance is going to increase with the longer the tube. There's two interesting sources of data that always kind of stick around in my thoughts when this conversation comes up. One is, they did this, you can look this up on YouTube, it's called Potinger's Cats, and he groups cats into eating raw food and then cooked food, and then generationally follows them. And by the third generation, the cooked food cats were had terrible malocclusions and underdeveloped jaws and all these behavioral issues, and we're basically weaker counterparts to the ones who ate the raw stuff.
Here we find the development of a second-generation cooked meat animal. The head has begun to flatten and is actually smaller than the comparable raw meat cat. The skull shows the major reasons for this change. The zygomatic arch is not completed. The nasal development is somewhat irregular, and the calcium content has fallen to 10%. Third-generation cooked meat animals show the most remarkable skeletal change. The skull is considerably smaller. It is flat with pointed features. The skull shows a poorly developed zygomatic arch. The bones are paper-thin and soft like sponge rubber. The frontal sinuses had developed in a peculiar fashion, and the calcium content of the bones had fallen to a low 3% by weight. Activity level is another index of interest. In this pen, there is an obvious difference in activity level between the raw meat animals and the cooked meat animals.
And then there was also, which I don't know if it's a nutrition or a stress on the jaw argument, or a combination of those two. And then there's other books on like going to tribes and stuff who have nothing to do with civilization, and they have perfect teeth and like well-developed jaws and smiles and so on. And then
I've seen those.
And then also monozygotic twin studies, where only a handful of case studies of like twins that I guess stick to a cleaner non-civilizational diet, and then the other one's like in civilization, and they look completely different, and they're, one has a breathing problem, the other one doesn't. So there seems to be something there. Your brother doesn't have anything though, hey?
His jawline was always stronger than mine. Not like, maybe, I don't know if a normal person, like a casual person, would notice, but I would notice growing up. However, he does not sleep well. His sleep is more like an insomniac now, and it's kind of always has been, at least for probably 10 years. But he doesn't have, he certainly had less problems, like OSA problems like I did. So, I do have this anecdote. When growing up, I regret it so much, but growing up, I remember not liking to chew a bunch of meat because it seemed like a workout on my face. And I was like, I don't feel like working out right now. I want to eat food. Like, give me it. Like, I want it mushed up and like soft. And my brother loved like thick steak. So I wonder if that's part of why he had kind of better development on especially like his mandible than I did.
Yeah, it could be. I do think that's the strongest argument, that it is a force upon your jaw cause. And if you deprive yourself of that, your jaw underdevelops. This does make the most sense. Or anything that would perpetuate or bring on mouth breathing.
Yeah, I would think,
obviously, once you start mouth breathing, it's just like a terrible spiral, right?
Yeah. And maybe to your theory about the choking, I wrestled and my brother didn't, so maybe I got too many headlocks, and maybe that hurt my.
I wrestled too.
Oh, cool.
Yeah, like high school wrestling, like free.
Yeah, I did 8th and 9th grade. Yeah.
That was a good time.
Yeah, I loved it. It was great. I was going to ask if you had any co-occurring, we could keep it short, but any co-occurring health problems, as I often see that in this space where, say, someone has breathing problems, but might also have some other illnesses coming into play.
Well, I think when I was younger, I was diagnosed with ADD or ADHD because of this. That's one.
Mm-hmm.
I don't what else could I say? They diagnosed me with depression and anxiety, which makes sense. I would say it was all psychological. It was just a brutal, like, I know I could do so much more with my life if I just felt normal, and it would just tore me apart, psychologically. Like, it's just so depressing to be sidelined from life in my prime. Like, I had all these dreams, and you're like having to like come to terms with maybe none of these are gonna come to transpire, and this is gonna be my whole life just suffering, and then like what's even the point? But for what it's worth, I've shifted that position after being in this space now for 10 years, and I think it's actually very hopeful. And with AI and all the additional attention that's getting poured into this, I think we're going to figure it out for everyone. And I think that, I don't know what the numbers are, again, I don't think there's literature on this, but most people, I think, can get to a life that they are satisfied with. It's just, we just don't fully understand it. And there's just some phenotypes that are falling to the wayside for a variety of reasons. But I would tell everyone to stay hopeful, because I literally you know, was in that position of despair, and it turned out okay, you know. And sometimes the worst thing that happened to you is the best thing that happened to you. And I think that if we can, some people probably find this inflammatory. So I can understand if you do, and I apologize. I don't mean to make you feel that way, but if you can try to shift the way that you view things, and maybe not see the bad stuff as so bad, and that life is happening for you and not to you, and maybe there's a purpose behind it, I think that can help too. But yeah, that's my little passionate speech for everyone.